Okay. You take over. Okay, now you advance. Okay, gently. Now just point down, clockwise rotation. Yeah, slightly anti-clockwise now. Just, yep, and advance. Now, lumen view, full luminal view. No, don't, yeah, skip. Okay, that's fine. Now get it clockwise and up. Point up, 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 up. Point your tip up, up, big wheel, up, 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 up. Keep pointing up. Hold your scope there. You have to, and now advance. Advance. Okay, that's fine. Wash. Very good. That's good. Now again, point. Yeah, give a clockwise torque and try to withdraw the scope with clockwise torque. Clockwise torque and withdraw. Right? Okay. Then tight clockwise torque and withdraw. Point up, up. Point your scope tip up and clockwise torque at the same time. You should have the lumen in full view. Okay? Lumen in full view and withdraw. Withdraw करें scope. और point up, up. हाँ ये थोड़ा सा distance. Oh my God. अच्छा हाँ air suck करे. एक मिनट सर इसको मैं वो कर देता हूँ. Let me do it. Oh God. अच्छा right okay. Let me. अब उस स्कोप गाइड हो जाएगी. अच्छा अब कुछ बेहतर हुआ है.
Waqar, the patient is supine, so you actually change the patient's position because
Yeah. Normally, if you are in the sigmoid colon and you are having a bit of difficulty with looping, it's always a good idea because if you change them to supine position, it gives you a 90-degree advantage in torque. So it makes life easier. Now, if you look at the scope guide screen,
yeah, we can see it. It's very straight. Yeah.
It's very straight.
Yep.
So that shows that now it's a piece of cake for him. He can just go through. The only problem here was that the patient was very distended, and in fact he was burping upwind, which means that it's seriously overinflated. So I've just decompressed him, and now you can take over, right? Asha. You are as we approach.
So
we are in the splenic flexure area.
If the insufflation is actually your enemy.
Now just suck the fluid off. Asha. Now always remember that your biopsy channel is at 5 o'clock position. So no, just wait a minute. Just let me show you. The biopsy channel is at 5 o'clock position. So if you want to suck fluid, this is the way to do it. You bring the fluid at 5 o'clock position and you suck, just put the suction halfway down and you just slurp up the fluid gently without suctioning of the mucosa or collapsing the lumen. So you can suck the fluid out, but you didn't collapse the, because I was just sucking straight into the fluid. Likewise, if you have a polyp or any lesion that you want to target or biopsy or snare, always bring that lesion at 5 o'clock position. Like I've again brought the fluid at 5 o'clock, because that's where your biopsy channel is, and that's where you can easily carry out the procedure. ठीक है? Okay. अच्छा. जरा give it a clockwise torque. Clockwise you lose हो गया. हाँ. आराम से बेटा. Just advance slowly, gently. It should be a deliberate movement, and not. You are quite all right there. Okay. Just advance. Have fine. Now point up. Point the tip up. 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 Keep going. And now just advance. Just like now, keep advancing. Yeah. Just don't inflate as you don't inflate. You don't need to inflate. Take your finger off the inflation button. Yeah. Now advance. थोड़ा सा deflate करें. Just suck a bit. हाँ. Up advance your scope. Gentle. You can go now. It shouldn't cause you. At this stage, if you want to make life easier, you can stiffen the scope up. Stiffen करें इसको, छोड़ दो उधर से. अब पूरा घुमाएं, full. Yeah, it's either 0 or 3. There's no in between stiffener. Yeah, that's it. ठीक है? That will just give you a bit more support. Okay, now advance. So you now take your finger off.
Waqar?
I'll hold your finger. Okay.
Once you've done this, explain to us why did you use the stiffener?
It is just to give you more support. It gives you a bit of a body in the sigmoid colon. So it will, if the it stops the scope from looping in the sigmoid. Normally it shouldn't happen. With good technique, I normally don't use the stiffener as a routine. But for beginners, I always advise them to help them. I'm just holding his middle finger because he's got a bad habit of overinflating the patient.
Yeah, I was looking at that.
Yes.
Yeah, we can see that here.
So that is because, and that's why he has been burping up wind from his mouth. And if you see that, that means you are seriously overinflating your patient. Okay, ठीक है, that's good. Keep going. Sorry, I have to do it because he's got a bad habit.
Back again.
No, I'm holding his finger. Up इस वक्त you don't need to inflate even a single milliliter of air. It's very inflated, so don't make the procedure because the more air inflate, the more complicated it becomes for you. The colon becomes bigger and bigger. अच्छा, अब जाए. Don't inflate anything. Advance.
What you're going to do is you're going to make your colonic configuration more difficult.
Advance करें ना क्या किस लिए खड़े हैं आप?
And you also create resistance. So air can be your worst enemy in colonoscopy. It is your friend as long as you
Advance.
use it little.
Yeah. Point up. ऐसे शाबाश. Good. Keep going. Yeah. Keep going. थोड़ा सा clockwise. And point up. Advance. Point up. Up.
We can,
More.
I'll ask Waqar to
Yeah, that's
make
it.
the patient
Keep
up
going.
for 1 minute
Keep going.
and start feeling.
ठीक.
Just do a rotation,
ठीक.
make a loop and you know.
ठीक.
You can see the scope is very straight.
हाँ जाए. You can still go.
The gray area tells you that the scope is
No, you are losing your ground, so it means you don't have enough torque on the scope. You can go back again. Go back in. Right? Keep going. Now if you look at the scope guide, it's got a slight mobile splenic flexure, which is making life a bit difficult, but it's okay. You can still advance. Clear your lens. Yeah, keep going. Don't suck. देखो जो वो होता है ना, जो steady state होता है उसको change ना करें if it's causing. So don't suck or blow air unnecessarily. If it is stable like that, you don't have to do anything. ज़रा advance करें, उधर keep looking at it and advance. Give it a slightly clockwise torque, और इधर we'll use a bit of a wash. अच्छा, हाँ. अब इस situation में you can't do anything, because you can't see anything, right? So what you can do is withdraw your scope a bit. Whenever you in endoscopy, the golden rule is if you can't see, withdraw and give it a bit of a torque because your lumen is on the 1 o'clock position. 1 o'clock, or we torque there, give it more torque, clockwise torque. You lost your position now. Okay, I'll just show you. Okay, just let me go there. Okay, so अभी जो है तो इसमें काफ़ी looping है. So what I'll do is I'll just try and take that out for you, and now let me try and get you back in there. Okay. हाँ? क्या चीज़? नहीं वो उसकी चक्कर नहीं है, looping की चक्कर है. अच्छा, अब यहाँ पे आके जो है ना, ये बाल प्रपोर्शन नहीं आपको नज़र नहीं आ रहा, तो हम ऐसे ब्लाइंडली एडवांस नहीं करेंगे, ठीक है। आई लुक अराउंड फॉर द लूमेन, तो विल सक अ बिट ऑफ द फ्लूइड आउट। यू कैन डू अ बिट ऑफ वॉशिंग इफ यू वांट। थोड़ा सा वॉश कर लेते हैं। वो यार काम नहीं करता था। सेट हो गया ऐसे, चलो अच्छा चलो खैर, अभी मैंने इसको थोड़ा वो ज़्यादा टॉक दे दिया है, तो आई हैव कम टू द, अच्छा थोड़ा सा वॉश कर देते हैं यार एक। हाँ बिकॉज द इम्पॉर्टेंट थिंग इज यू हैव टू हैव अ क्लियर विजिबिलिटी बिफोर यू डू एनीथिंग, ठीक। So let's give it a good wash. चलो मैं कर देता हूँ आगे होंगे के सामने। हाँ जी, ये दबाओ यार, ठीक है। लेट मी, ठीक है। तो हाँ अच्छा, अब देखें इस वक्त मैंने ये निकाल दो, हाँ हाँ पीछे कर दे। मैंने वहाँ पे वो किया है, ऐसे था ना, ठीक है। वी आर स्टक इन अ ब्लाइंड वो ना, ठीक है। यहाँ पे आप स्टक थे, ठीक है। इधर वी वेंट देयर, जस्ट एडवांस हियर अगेन, ओके। यहाँ पे पहुँच के अब इसको आप अभी आप ले लें मुझसे, ये वापस कर दो यार, एक साफ हो गया। हाँ वापस, ठीक है ठीक है। अब उसको एडवांस करें, तो इन देयर इट शुड गो इजीली। अच्छा अब जाएं इधर, यहाँ पे होल्ड इट, इधर अब टॉक दें क्लॉकवाइज, क्लॉकवाइज खूब बहुत सारा, कीप गोइंग। हाँ अच्छा, अब यहाँ पे थोड़ा पॉइंट अप, नहीं आप ओवर चले गए, उधर वापस जाएं, थोड़ा सा ऊपर पॉइंट करें, नीचे ये पडल है ना, नहीं नहीं ऊपर पॉइंट करें सर। हाँ और टॉक दें और ऊपर पॉइंट करें, हाँ ये ठीक है। इधर और भी टॉक दें, अच्छा अब यहाँ से सक करें फ्लूइड, हाँ ये जगह पहचानिए जी, ये हेपेटिक फ्लेयर नहीं है, इसी कम है। ये देखें सामने अपेंडिक्स आपको आंखें मार रहे हैं। और इसको ज़रा थोड़ा वो, हाँ हाँ वैसे शाबाश, ठीक है। दिस इज, हाँ आप देखें कितना क्लियर सीकल पोर है। साथ कैन यू हियर अस, कैन यू सी अस? नहीं है,
Well done.
हाँ
Yes, well done. We can see everything.
yeah, okay, so he's done it with
Yeah,
a
it
bit
was
of,
very nicely demonstrated, and I was just telling them I just, sort of switched off the mic here. We didn't want to
Acha,
disturb you.
that's fine.
But we can
Okay.
see the
Appendix
appendicular
orifice.
opening very clearly.
Yeah, and the ileocecal valve
And
is
we
at
can
9
see
o'clock.
we saw the ileocecal valve even before. So you're now going
Normally-
to try and get into the terminal ileum?
Yeah, well, I normally don't encourage them to do it because when they go back, they are obsessed with it and they spend hours doing it and inflate the patient again with lots of air and make it. So if they can cut up to,
Maybe you can just show us how
okay,
you
fine,
do it,
chalo.
and so that at least for those who are sitting here, it would be nice.
हाँ, चलो।
Looks like a relatively easy ileocecal valve because you can see the port.
ठीक है, तो ये you can see appendix तक आप जाके you go there and as you withdraw, you see the ileocecal valve at 9 o'clock position, and I can just see it coming into the view, right? So there it is, pucker. Oh, right. So, and it's just a bit. Sorry. I'll just get a clear view of it. Okay, it's down a bit.
Pick up the one that you are comfortable. There's more than one way of doing the same thing.
That's the ileocecal valve. Yeah, ठीक है। थोड़ा सा आगे कर Yeah, there it is. Oh. Just slip fast. Yeah, there it is, right? Okay. So, it has closed up on us.
This one is a floppy one, so he's trying to get in. It's actually
Yeah. Yeah. Oh, yeah. Electronic biopsy forceps दे दो.
yeah. It's one of those floppy ones which kind of looks very tempting, but when you try and
Yeah,
get
it's a very floppy
yeah,
valve.
so
it
it,
just
whereas you try and get in, it
yeah.
actually
I'll just
does-
show you can, you know.
it's
the problem
okay
is
if you're
you can
running
use the
short of
biopsy
time.
forceps as a guide wire, but it makes it a bit uncomfortable for the patient because it will
Well, if
cause,
you, it's not really indicated as long
Yes,
as
yeah,
it's
it's not
not, so we
indicated,
can leave it and
yes,
do
yeah.
it in the next patient if you
yeah,
want.
yeah, that's right.
Okay, it's up to you.
I'll just there it is. We are in the forceps is there, so you can follow it up with your scope.
We can see it clearly,
Yeah,
the
down,
forceps, and we
right,
can
okay.
see the ileacecal.
Ileacecal valve there.
Yeah.
So you can use that as a guide wire, but it's usually, you know, in this type of situation, it's quite uncomfortable for the patient. So I would rather not.
No, that's fine.
Yeah, okay,
You've
so,
demonstrated it very well.
Yeah,
Thank
okay,
you,
so that's-
Vakar.
Okay, fine. Thank you. Right. Okay, so now the important part of the examination is taking the scope out, right? So what you do is, normally what I would, one or two things. If you are sucking the fluid off, so again bring it to 7 o'clock, 5 o'clock position and suck like that, okay? So, as if you are sucking up the last bit of Coke with a straw from the Coke bottle without causing that slurping noise, okay? So it doesn't collapse the lumen, and that's how you do it, okay? Now what you do is clear up all your loops. Make the scope nice and comfortable for you. Unstiffen the scope so it's nice and maneuverable, right? And then inspect as you come out. You don't have to clear all the feces, but anyway. Okay? To keep the lumen in full view, and then we'll see. ठीक है, आप आहिस्ता आहिस्ता आना शुरू कर दें, and don't inflate any extra air. Clear your lens. Lens clearance is, yeah, okay. अब आहिस्ता शुरू करें, start coming out. Yeah. Okay. Right. Yeah. Okay. Now, just a minute. When this happens, you know, you have to go back in again, right? Okay. So you see, in one flick of an eye, you have lost so much ground. See all that ground without inspecting, right? So that was a bad withdrawal technique, right? So this is at the hepatic flexure. So you went right from the ascending colon to the hepatic flexure. Now when I'm coming out like that, just watch, then you can do it yourself, right? You will see the fold coming in front of your field. So just see where it's coming from, right? उधर देखें, इधर नहीं, right? Okay, so we are coming out gently. And as we come out, right? So now this fold is coming in front of your field, right? So when you anticipate it's coming, you look away from it, and then this one. You've not lost any visual field there, right? And then if you are unsure, always you can go back. Now this is coming in front of your eye, so you move away from it there, right? And then when you cleared it, then you come back over it again, and again it will come into your field of view. So you go over it again. So point away from the fold that comes in your, now this fold is coming in your front of your eye. So we'll move away from it, we'll look away from it, right? So when you cleared it, you go over it again. यहाँ पे ज़रा मतलब गंद है तो you won't be able to see much. Okay, so you carry on with your withdrawal, right? So अब जैसे ये आएगा ना, तो जो ही अगर इधर से आ रहा है ये, तो आप उसको point out उधर करेंगे. So when you come there, so you will then, again it's coming towards you, तो इसको आप ऐसे करेंगे, देखें, and then you come, again it's coming in front of your eyes, so you point away from it, and when you point away from it, it wouldn't cover your field of view. So when it's cleared you, then you go back on it and you look on top of it, and again you go back in and look on top of the fold that was going to obscure your view. So the parts of mucosa which you've not covered, you cover on looking back at it. Okay, so that's how you do. Okay, चलो आप शुरू करें, and try not to suck too much. हाँ, चलो suck ना करें क्योंकि फिर आपका वो view खराब होगा. हाँ ठीक है, that's okay. Clear your lens. हाँ ठीक है, that's okay. ज़रा सा try to look behind the folds. आप ज़रा थोड़ी सी तेज़ी में आ रहे हैं. हाँ, clear your lens, clear your lens. हाँ. You would not drive your car with a muddy windshield. So all windscreen. So this is हाँ, ठीक है. हाँ, that's good. हाँ. हाँ ऐसे, that's better. That's better. That's good. Very good. Yeah. Okay, that's good. Yeah. हाँ, ऐसा से आए हम. हाँ. अब यहाँ से आपका फील्ड में आ रहा है ना 9 o'clock, तो point towards 3 o'clock. That's good. Now back. हाँ, now yeah, that's good. Excellent. Now go back and look at the fold there. अब 9 o'clock की तरफ point करें आप. पीछे यहाँ से हाँ. नहीं, थोड़ा सा और पीछे आ जाए. Withdraw a bit. Yeah. Withdraw. Now look. Yeah. ठीक है. Withdraw. Let this fold come into your view. Now go back up. That's how. Okay. So you are looking above it now. So that's the way to do it, so that you do not miss any part of the mucosa. Don't suction it because you don't want the mucosa to collapse. Leave it as it is. take your fingers off the controls. Right, okay, that's good. I mean, obviously, you can't do it perfectly now, it's your first time, but this is something you have to do as a homework. Work on the technique when you are practicing in your hospital. That's good. ठीक है, हाँ, look up, there, that's it, right? So you've checked that bit out. Now look away from it, that's fine. Now withdraw, look, yeah, look there, हाँ, ठीक है, look away from it, withdraw a bit more. Yeah, that's fine. Up now, you can look at it. That's fine. Good. That's good. 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 Look at across. Look down. Okay. Leave it. Let it open up. Don't inflict unnecessary air. It will open up itself. ठीक है. हाँ, सही है. Good. That's good. उस तरफ point away from it. Yeah. That's good. Right? Obviously the ball prep is not very good, so it is going to limit your quality of examination. ठीक है? हाँ. Up, point away. That's it. हाँ. ठीक है? थोड़ा सा ज़्यादा हो गया. Get full luminal view, ऐसे ना जाए. ऐसे हाँ, that's better. ठीक है? That's good. Clear your lens. हाँ, अच्छा 1 मिनट यार, इसको ज़रा थोड़ा सा डिकम्प्रेस कर देते हैं. कर लें आप. हाँ, हाँ, कुछ बेहतर हुआ है? अच्छा, असल में स्मॉल बाउल में भी चला गया ना. ओके. Keep coming. Right. उस तरफ. That's good. हाँ. Away. Go toward. हाँ. That's good. Good. Good.
That is the recommendation.
Yeah. इसको छोड़े.
Same applies in the you see that your stroke is going this way, you see what is this way, you stop, come out here, you know you got
आपका म्यूकोजा उस पर स्टक है. हाँ. एक मिनट वापस अंदर जाए. लेट मी शो यू. ठीक है, यू डू अ रेट्रोवर्जन. ठीक है. ये जो इज गॉट हेमोरॉइड्स. राइट. काफ़ी जूसी हेमोरॉइड है. रेट्रोवर्जन का ये होता है कि आप यू कम राइट टू द एंड ऑफ द थिंग. राइट. यहाँ पे आके यू गो बैक इन. ठीक. एंड ये अप एंड डाउन जो है उसको पूरा वो कर दें एंड पुश इन. एंड but it's best done in a it's better done in a left lateral position. लेकिन you can do it this way as well. ठीक है. तो इसमें ये होता है कि थोड़ा सा uncomfortable होता है. You have to go on the patient. तो right. Go back from there. Okay, challenge, first class. We've got hemorrhoids internal. Okay. Carotid side view.
The scope is staying static. See it staying static? Yes. And now it's coming back. A little bit of air. So what we've got, we've travelled further and we've got less scope in. And now if you look again, the scope looking back up at 12 o'clock. Alright? And then we go here. And I slow down to what's happening. I'm just looking at his eyes. And we just slow it down. And now we see where it wants to go. The scope wants to go. And if we look again, as the scope comes back, see where it's shiny, see where it's dark. And that's the side you want to go to. For some reason there's a bit of air trapped up above. Now if this is difficult for him again, this is a chap that we will bring over onto his right side. Now if you see what I'm trying to do, we're actually anti-clockwise torque.
Yes.
And what that's doing is it enables us to actually reduce the scope. There. See it? So we're under that fold now. And then just to there. So all of this is to try and get up to straight. As we go forward, again, on, a little bit of air, on and a little bit of air. And again, anti-clockwise, and then clockwise. Now this man's got a lot of spasm. So when you've got a lot of spasm, you've got a few options. Your options are, do we put some warm water in? Have you heard about using warm water? Warm water down the scope?
Warm water?
Yeah, warm water down the scope. Or you can use Buscopan. I don't like Buscopan. Glucagon.
Paul, can you hear me?
Yes, sir.
Okay, we don't get Buscopan anymore in this city,
So
at least.
What I'm talking about.
Not IV.
Well, warm water, my friend.
Warm water works most of the time, doesn't it?
Warm water works a lot of the time, and it's a forgotten hero, I think, in circumstances like this, because this is a chap where he had a very tight sigmoid with a little bit of spasm.
Still continues.
Yeah, it continues to be a little bit. But it's going forward nicely now.
Close.
Got him to slow down a little bit. So things are progressing.
We just
I think glucagon is something that we can use as well.
Yeah, the only thing is that it costs more than the cost of colonoscopy here almost.
It's a difference, isn't it, in worlds where something that I would ask for and take for granted. It's a bit like you guys, where you get a patient to come in and they've got some obscure pain, the patient, and I'm just looking at them, they're feverish, etc. We would be able to get a CT scan very, very quickly. I'd say you guys may struggle because of the costs, and you have to choose wisely the right test, rather than what tends to happen in the UK. We throw every test at the patient and then decide what's wrong with them.
You'd be surprised. CT scan is not so much of a problem. Glucagon is big problem.
Is it?
Yeah, I can get 10 CT scans. Getting one glucagon is more difficult. But the thing is that even you'll be surprised. I mean, here you very rarely use this, but in ERCP, I know everybody uses glucagon straight away.
Yeah.
I have not used glucagon once.
Well, I
in
think
almost now almost 8,000 ERCPs.
Well, I think it's a bit like colonoscopy. There's a lot of people who profess to use a lot of. Now, my friend, just one sec, sir. How much scope have we got in? 70. How far do we think we're round? How far do we think we're round?
I would transverse colon.
Transverse colon. Okay, transverse colon to us is more triangular, yeah? So this is still got rounded edges to it. So I would suggest that we were probably still in the descending colon. Okay, so I would suggest that we've probably got a large sigmoid loop somewhere. And judging by his tummy, if I press just gently, I'd say that we have got a large sigmoid loop. Now just drawing back the scope that way isn't going to help. Okay, so drawing back the scope, hold it there, anti-clockwise, and now go forward just a little bit slowly. You're trying to put clockwise torque on, my friend. Just take it back nice and steady and advance slowly. The bowel will actually take a little bit of pressure if you put it in slowly. It's when you put it in fast, it shocks him, and then you get a lot of discomfort. So slowly advance. Slowly advance. That's brilliant. Slowly advance. Slowly advance. We'll have a look at that on the way back. Okay. Let me just have a little look, my friend.
Yes.
So that's fine. So. You got a small snare? Thank you.
Paul,
Yes, sir.
so how many colonoscopies on average do you do a week? I guess 25?
No more, my friend. I'm doing probably. I did 14 on Thursday. I'm probably doing 10 a day.
That's 50 a week.
50 a week minimum.
Bloody hell. That's just colonoscopy.
Just colonoscopy. And I do probably twice, if not 3 times, that of gastroscopy as well. Right. When you're doing any kind of polypectomy, never adjust the scope into the position before you get your snare where you want it to be. So I always get my snare down, slowly open, my friend, slowly open. A bit more. Brilliant. Too much? Slowly close. Slowly close. Is that slowly? Do you make love like that? Slowly close. Ah, no. Right, slowly close. Slowly close. Love is blind, marriage is an eye opener. Right, Slowly open, boss. Slowly. That's enough.
Slowly open,
Yeah. Now pause. Now close again.
close.
Paul, what are you doing?
There's a tiny little farty polyp.
Oh, you're taking that tiny little thing out, which we saw.
Yeah.
Now, let me ask you something. This is a good point that has come here.
Open just.
We all tell people that polyps that are less than a centimeter are very unlikely to be of any significance, and anything less than 5 mm
Open again.
is even less likely to be of any significance. What do you tell the patient? I saw a polyp and I don't think it was significant, so I left it.
Well, the issues are that we've got is that on our bowel cancer screening, there we go, my friend. That's in this now. The thing about in bowel cancer screening, we've found high-grade dysplasia in polyps of 2 millimeters. We've even found large polyps with no evidence of high-grade dysplasia. So polyps themselves we tend to take off. I'm actually got issues with it at the moment because we have polyps where small ones where we've been taking off and they're all coming back as just showing metaplasia, and I think we are guilty and overcautious with some of our polypectomy. I think MBI is a poor way of imaging it. I'm not a great fan of Paris and Kudos because what we're going to do with those is that they come into our play now in colonoscopy, and I think, what am I going to do with this polyp? Am I going to take it off or am I going to leave it alone? The fact is, I'm going to take it off.
Do you think a lot of
That's
people,
so.
Hey, Vakar stood behind me, I didn't know.
Wakar, is that your practice too?
no, what I tend to do is, I'm a bit like Paul, because the problem is some of our people are obsessed about improving
Absolutely.
their figures of adenoma detection rate, and I don't care about that because they take out sort of minuscule polyps which are totally either metaplastic or got no use, and even
Yes.
if you leave those polyps alone, they are not going to change into cancer for the next 12 to 20 years. So personally, I feel that it is a bit of a waste of time trying to do that, and then those patients get put on the surveillance programs and they unnecessarily block the system. I think people are more obsessed about improving their adenoma detection rate.
So if you see a small, less than 5 mm, typical salt and pepper
So I am
polyp, what would you do?
I normally, because usually we have indigo carmine, ready in syringes all the time. So I would just spray it with dye. NBI is useless.
I agree.
I never use NBI for anything. So if I thought I use, I would use some dye spray and then check it out. But as Paul said, even those classifications are not sort of.
You're either going to take it off or not take it off.
Exactly.
And the fact
Most
is,
of the time I just ignore that.
the big thing as well, Sad, over in the UK, we've got these guys who are called super polyp detectors. Now, super polyp detectors in the bowel cancer screening program are guys who've got a polyp detection rate of 65% or more. Now, when you sit down and look at my bowel cancer screening list, I will start at 8:30. Now, straightforward bowel cancer screening list, I will have finished for 10:30. That's half an hour per patient. Technically, I'm given 45 minutes, but half an hour per patient. These guys will spend an hour on per patient, but I'm not on about an hour to do the procedure. I'm on about an hour on withdrawal. They're even talking about spraying their entire colon and then continuing. So I know one particular consultant who's doing bowel cancer screening, who starts their list at 2 o'clock, 4 patients, and has still not even finished their last patient at 7:30 at night. That's 4 patients. Now, if you think that is a good use of resources, then think again.
My problem is that if I write there is a small tiny polyp and I don't take it out, then the society that we live in, we have a lot of issues. They go to another doctor who says, "Oh my God, This Dr. Sadhnia's left a polyp
Again,
that can turn into cancer. Now, so what will happen is they will end up having another colonoscopy, and that other person will go and take that polyp out, and so my practice is generally to take anything that I see, which I think is like polyp, take it out. I agree that quite often it's totally unnecessary.
Well, I learned from you last time that if I see a polyp, I'll take the thing off from here. But if that was back in the UK, I would have ignored that polyp.
Yeah.
That wasn't anything of
Yeah,
significance.
I totally agree with you. My only problem is either I don't mention in the report, which is fine.
Yeah, well,
But if I
choose to do
mention
that.
in the report that I saw this polyp,
Yeah.
even if I take a photograph,
Yes.
I know there are more than many who would say, no, we don't agree. Polyp has to be taken out, so no matter who it is. So I think it's not the correct practice, but unfortunately that's how we work here.
It's very quiet, isn't it? He's a quiet man. He's not like the American, is he? He's not like my American friend earlier. You know, he was typical American. Oh, typical American, all talk. Hi.
पूछना आप क्या करना चाह रहे हो वेट कर रहे हैं आपके आंसर क्या कह रहे हैं आप
अपवर्ड देखना चाह रहे हैं ना इसको
You want to see upward.
Yeah. How?
हाँ बताएं कैसे
by doing the right upward, right wheel upward.
So read there. Look at the screen. No. So your big wheel is forward. And that's how come I knew that's what was happening there. So to go left, it's here. Draw back, hold on to that. Advance. Now, advance. Let the scope come back slowly. Bit further. That's it. And let the scope relax onto the bed. Big wheel back. That's it. And neutral. No. That's it. Only comes back so far because all you're doing is lifting it out of the way. And now you can find your way. Because all you're doing is lifting it out of the way. That's good. Right, we've got too much air. You're pressing on the air there and you're filling him up. Let me just take it down, just a second, okay? Because I could tell he was getting very uncomfortable. So to reduce what you've got, back. Now he'll feel a little bit better, not too much better, because what happens is we shut off the right colon because of the air that you've put in, okay? So we have to actually get it to tease round. Now he'll start to feel a little bit better, and if you watch, I'll take the scope back, keep it there, suck on down a little bit more, and now go forward. And it's because of the air that's gone in. You just sat on the button and filled in full of air. Okay? So now we just want to come back. Come back. And now go forward again. is the water is what we want, not the air. Water is what we want, not the air. Okay? Now I've chose to do that because you've gone in an angle that's causing the scope to feel a little bit rigid. And then we'll come off there now, so we take that out, and then the scope will sit central to the lumen. So we've got little wheel neutral, this time the big wheel is back, so as we draw back, the scope will neutralise and then can go forward. Okay? So if he comes onto his back, watch what happens to the scope as he comes onto his back. All we're doing is keeping it central, and then we draw back, suck, 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 come back, suck, and then go forward. That's fine.
Patient is complaining the pain.
Look at his toes. So the little wheel neutral. Always make sure it's neutral. Just checking we have water. Now what's causing this patient pain is too much air early on. Too much air, yeah.
Paul, you
Yes,
just
sir.
did something that our American colleagues found very amazing. So can you show him what you just did? Again, you did that.
Right.
You're transmitting loops and you're bringing loops. What are you doing?
What I'm doing is that this chap has had a little bit too much air put in and it's stuck at the hepatic. And I know that if I put this torque into the scope, I'm actually using the torque in my favour as I draw back the scope. The transferring a loop into the umbilical isn't a problem. The problem comes is what's outside represents what's inside, and I'm trying to keep the scope in a straight line so I can actually intubate the actual colon itself. What I'm going to do now is ask him to go back onto his left, and then all should become apparent.
After you're done with this case, just while we are all watching you, we'd like to see you put a loop into the umbilical cord, and then how do you reduce it? Okay.
Okay, so that's it out. That's it back. So as I go forward now, you'll see that I'm watching the teeny-eyed air, so it goes up. Big wheel back. Now to increase that torque, you can see big wheel back, anti-clockwise torque with the little wheel, and then clockwise torque with the scope. Anti-clockwise, clockwise. And all this is just to keep the scope coming backwards. And then as I take back, and then round again. The problem comes when you get people where we've put too much air in, then it becomes a real big problem because it shuts off at the flexures.
I was just telling the delegates here that sometimes you put so much air and make it so difficult that even when you hand it over to somebody who's is very experienced, it's not very easy. So air is something that you need to be very.
So what I've done now, I want to put anti-clockwise torque in the scope. I've actually put the anti-clockwise torque and the buttons are pointing over here. If I actually now turn the scope back, I'm increasing the anti-clockwise torque, but the tension is in the umbilical. So I don't have to then force the scope round with this hand. I can actually leave this free and I can put the torque in the scope. So that's what that's about. I know where the scope wants to go, but the scope doesn't want to go. So when I come back here, I'm actually drawing back the scope slowly. Now I'm going to take that loop out, but I'm going to turn the scope so she sits off to one side, so I don't allow that anti-clockwise torque to fully come off yet.
How much scope has come out? How much scope was in the loop?
Sometimes you just have to use the little wheel to adjust in the right colon when you've got a lot of scope in. Torque steering loses its effect. And sometimes you just have to use the little wheel, which I don't like doing, but I will do if necessary. Now this is coming back to where we were talking about reducing loops, and it pushes you back if you haven't got anywhere for the tip of the scope to go. Now you can see where the tip of the scope wants to go. Okay, my friend, can you go onto his tummy? Tummy.
बिल्कुल उल्टा जाओ फेंक करो
So what we've done is change position so he's onto his tummy. Scope is possibly coming anterior, so I'm actually coming back with it. I want to make the scope feel comfortable. Onto your tummy, hip square to the bed. If you notice now the scope staying static. And we've just freed up the scope now. Point the buttons over to the wall, have a little look. It's always interesting when you find guys who are supposed to be reasonable at doing these things struggle. And then it just makes people realise how difficult the actual colonoscopy is. And I think it's actually refreshing for people when they see that, and then they think it's, oh well, he's either not as good as what they think, or colonoscopy is hard. And I actually think colonoscopy is hard. There. At last. Yes, please. That's better. So for my
Oh, well done.
I like. Do you know?
I saw a little bit of excitement.
Well, in the UK that's great excitement. Over
Yeah.
here, to you, it's boring, but to me,
No, I find it exciting. At least something is alive there.
so I personally, the difficulty with this one is the fact that too much air early on, going in with a too much clockwise torque to initially, that does cause a lot of problems, in particular late on. What I'm showing you here is that you can actually torque the scope in any direction you wish, even in the cecum. That's what I was just showing you there.
Yeah, we saw that.
As you come back, you just draw the scope back, big wheel back, a little bit of air, and then the scope will sit on the mouth of the TI, hopefully go in. And sometimes
Just
not.
missed it, yeah.
I tend to now blow water. Just back there with the little wheel back. And there she blows.
There is your...
So blow water helps the treat straight in. Now I've actually, I agree with you, Saad. Colonoscopy is very important, but the most important thing is to actually get into the terminal ileum wherever possible. So I try to intubate it. Don't beat myself up if it's not necessary or essential, but the most important thing is to do it because there's time that you need to do it. If you don't do it on a regular basis, you can't do it.
Yeah, I totally agree with you, Paul.
Clean your lens. So in this case, it would have been easier if we think about if you remember the inner tube thing that we did last time, Saad. This would demonstrate what happened there if we actually could get access to an inner tube at some point. That would show that. An innovative use of a drinks bottle. Well done.
What was that?
I'm just looking at your large drinks bottle. I think it's great. In the UK, they wouldn't use that at all. You know, we're not allowed to use anything that isn't sterile, and we're putting stuff into a non-sterile area, and yet we have to use sterile water. We have to use.
And you also started to put, the fecal transplant. So how do they make that sterile?
I haven't got a clue, my friend. They invent all sorts of bloody stupidity. Yeah. So.
I remember your remarks when I was in Mansfield at your hospital, and you had some bug that was grown from.
Oh yeah. In the machines.
Yeah.
I went mad. So let me do this, my friend. I'll show you what to do. Because when you get poo onto the scope and you can't get it off, the trick to do it is to put it right against the mucosal wall. Keep the water going, just against the mucosal wall, just for a second or so. There you go. Does he like you? Eric's getting passionate here with Wazim, and he's worrying me. Slow. Now, for some reason I gave you a straight scope and now you've got all sorts of tension in the scope. Okay? That's better now. I think it'll help you. What do you want? Yeah? It makes him work for his money. Auntie. No, that's uncle. Auntie. Good. Now he understands. On the first day, everybody thinks I'm blowing him a kiss. I'm going to kill that fly. That's enough. Come back. Come back. Excellent. You're a typical surgeon. There we go, my friend. Now big wheel back. There. Big wheel forward. There. Big wheel forward. Yeah? Happy? Suck. Keep going. Wonderful. Now what would have happened there, Sard, back in the UK with a lot of guys? They would have taken the scope right back to the rectum and started again. I personally feel that when I have a trainee with me, that if I like to see and show them they could have completed the test from where they got completely stuck. And we didn't take the scope back, but I had to try all sorts of things to get it round.
We had that discussion, Paul, as I am one of those who would have actually, who might have done what your other colleagues do. But I was just admiring your skills and your patience both. Paul, there's a question while you're working on it, if you can take it, or I'll just ask Waqar to answer, or if you want to be quiet, you can just
I'll be quiet.
you can just chip in when you want to. The question was, when we're doing colonoscopies with OPDs and everything else, should we have a separate list of colonoscopies, preferably, or we should just
He's asking
do
Waqar
one
a question.
today, one tomorrow, one day after,
what's the
and
question?
two day after?
That's where we were causing a lot of. We did the polypectomy. Do you remember? Keep coming. Keep coming. Now, at this bit, put him back onto his left because you're nearly into the rectum. So. There, see, it comes back. As soon as you put the scope onto the trolley. There, see? Brilliant. Right. So we're there. Big wheel forward. Yeah? Now, big wheel all the way back. No, back. Back. Good man. Little wheel back. Good. Advance. There. No, 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 no. Keep there. So it's so. See it? Don't force the scope. What you're doing, a lot of the time, I'll show you in a moment what you've been doing. Okay? So here, and then draw the scope, and now let it come round. Okay? Now rotate the scope. This way. Let me show you, because you've got it right. You've got that right. So you're back, and you're back. Okay? Keep it down in a straight line. And then let the scope come back round. See it? And then there. Yeah? And then take the scope out. Excellent. Now, hurting him? Stop. Okay. Just take the tube out because that caused him a lot of pain. No worries, my friend. These two had a go. Well done. Too much air. Is that it? Are we done?
Yes.
Are we finished?
Yes. You have to.
One more?
One more colonoscopy.
Yeah, one for me.
Dr. Saad discussed with you.
Did he?
Yes. There's a patient in another unit diagnosed as biopsy.
First springs. Shed loads. Shed loads. Can you say shed loads? Shed loads. No? Shed loads.
Shed loads.
Shed loads.
Yeah, we can hear you, Paul.
Wonderful. So, Vakar,
Yeah, go on.
this is a young lady that they're questioning has she got her springs.
Oh, yes, yeah. So you're going to take some deep biopsies? Yeah, use the well technique.
So what I'll do, I'll demonstrate the technique for doing it.
Yeah.
She's also a lady that they've done anastomosis not so far up, but we'll take this biopsy
Yeah,
and I'll show you how I do it.
yeah.
Quite sore that is, isn't it?
It is, yes, it's very colitic type mucosa.
So if you notice, compared to the guys when they've gone in, I've gone anti-clockwise straight off and now gone clockwise.
Yeah.
I won't be going much further.
Yeah. You just give it
really.
a bit of a flush to, so you can, because I'm sure you can see it much better than me, but...
Sorry, Vakar.
I said, can you give it a bit of a flush so that we can see it better, because I'm sure you can see it better directly there, but it's not projecting.
It's not projecting very well.
No, especially when you get... just over there, yeah.
Okay.
Yeah, that looks very sore.
It's very, very
Gosh.
sore. So what you've got to be careful of when you get
Um,
someone with this sore bowel is how much pressure do you put on in there.
Yeah.
Oh,
This is not Hirschsprung.
this is not Earthsprungs, my friend.
No, it's definitely not. Paul, my main, I don't know what the rest looks
Hello?
like, but
Hello?
this is something which can be
Hello?
apart from inflammatory bowel disease in conditions like ischemic colitis.
I cannot hear him.
This, in addition to inflammatory bowel disease, this type of appearance can well be caused by ischemic bowel.
Yes.
Because I've seen quite huge punched out ulcers in, vascular obstruction. Yes. Yeah.
Where's she gone? Okay. So I'll wait till the lady comes back.
Yes, it doesn't. The appearance not sort of classical.
The female
Yes,
is.
I mean, positive, possible.
So what I wait. I don't do anything unless the female chaperones are back in the room. So I just stop and I sulk.
No, it's not pseudomembranous. It doesn't look like pseudomembranous. It can be, but the endoscopic experiences are not of pseudomembranous. Yeah, that's better. Yeah. What was, I understand this lady had a resection of the bowel.
She's had a resection, my
What
friend.
was the indication for it?
Well, she had obstructive symptoms, and so I keep trying to take pictures. Well, we're round.
Yes, yeah.
Paul, she just had an ileostomy, no resection, I have been told.
All right, okay.
That's what Sajda tells me, because this is the patient that was just referred this morning.
Yeah. That still looks pretty abnormal. Yeah.
Now, all I can think it's probably is enterocystic anastomosis. If this is what they were saying, that they've done a resection.
What we have been told is just simple ileostomy.
Sorry, gents, can't hear you.
Am I right, Sajda? Just simple ileostomy.
I'm sorry, chaps, I can't
The
hear
surgeons, the surgical ward that sent this patient or referred this patient to us told us that they just did an ileostomy. She only has had an ileostomy.
you. Okay.
That's all. So I'm not sure. But that's what the information we have. No, they just did it. I think because maybe she was severely constipated, I assume they just wanted to do a. They've defunctioned the colon, that's all. I don't know whether it was the primary ward that has referred to us or this patient was actually referred to them from somewhere, and so we don't have that information.
Okay.
All we can see is the colon doesn't look like a normal colon at all.
Yes, please. Yes, please. Yeah.
And it's pretty diffuse.
No. Close. Open. Close. So did you see what I did?
Yes, we saw.
And don't put, that's to see right round the colon. So I didn't push too far in at all. So what we will do is take some more biopsies as we come back, and I'll do a better demonstration when we get into the rectum. So I would have preferred to have actually been into the small bowel, but now these are the biopsies that I think are more important. Yes, please.
The number of biopsies that we can count, there is no number.
I tend not to take biopsies with a second bite. Some people do, they say biopsy. I lose the second one, so I always tend to do single biopsies. The reason for that, I wasn't singing to you Bye Bye Love, I was actually wondering why the thing was squealing in my ear. So, bye bye love.
Yeah, we all have, I commonly don't, but sometimes I do. If I can get a good bite second time, then I will. But
Right, let me just show you what I tend to do on a biopsy. This is the most important thing. When you touch, open, close, pull, so it tents, then pull. So in a I slow everything down. That was slowed down immensely. So I'll show you that in quick, as in standard, what I would normally do. So you touch, so the forceps will come down, you'll see. I'm not blowing or anything, getting close now. I can feel it rattle, touch, yep, done. And then I pull it, and I see it tent, and if you noticed, I aim for the ridges of the folds. Think of a washing machine, the blades in a washing machine that tumble round, and they're the ones that come in most contact with the colon, in the colon with everything that passes through. So again, just a quick one just to show you. So I'll slow this one down. So again, it rattles as it goes into the bending section. Touch, yes please, yes please. Tent, pull.
Paul, I've got some more information on this patient.
Yeah.
They said that this patient was seen with intestinal obstruction. She was opened up thinking she's got obstruction. When they opened her up, they found a very large dilated colon with no obvious abnormality on palpation or whatever they examined it with. And so they left the colon. They didn't do anything. They thought this was probably some kind of a neurogenic colon, and they did an ileostomy just to relieve that obstruction. But obviously they
The problem comes is that when someone's got an obstructive colon,
But
they're quite dilated. It would have been unsafe, I suppose. I don't know what the size of the colon was on imaging. And
I don't think they. No, you see, the problem is that we don't know that because this is something that the people who were actually, but she was opened up thinking she had intestinal obstruction.
yes,
And they thought this was probably in Pakistan when you're opening, quite often you think about tuberculosis, an acute obstruction. So I guess they opened up thinking they would find something in the small bowel. And then they went in, they probably found a very, very dilated large bowel, which could be what Waqar is saying at that time.
yeah.
But that's disastrous. So, fortunately, they just did an ileostomy, in which case what may have happened is that the colitic symptoms obviously kind of...
I think this is exactly what we discussed in the beginning, indication, contraindication.
Yeah.
This would have been a contraindication to a colonoscopy. Number one, it was an acute abdomen. Number two, it was a dilated toxic dilatation, which I listed as contraindication. And number three, if it's acute severe colitis like this, so ideally, they should have given more information about this patient.
So what I'm going to do now, Vaka, is just do a slow demonstration. Now I'm in the rectum.
let me just clarify this. What happened, surgery, ileostomy was done some time ago. Today, the patient has come electively for this procedure, doesn't have any obstruction. No. This is what you're seeing is not a dilated colon. We can see it's not. And the even the colitis is not too bad. But the issue here is that when she actually presented to the surgeons, she presented as a case of intestinal obstruction. And that's why they opened her up. And when they opened her up, they found a very dilated colon, so they didn't do anything to that. They actually just did an ileostomy and came out, thinking this is, as I said, possibly Hirschsprung or a neurogenic colon.
Okay.
But today she was stable.
Now, because we're in the rectum, I'll do another one of those biopsies just to demonstrate. So that's what I've just done to the left. So it's quite a deep biopsy. It's standard when you come against a GIST or anything similar to that. Hirschsprung's as well. It's a standard way of actually testing for Hirschsprung's. So I'm just trying to clean the lens. For some reason, getting a lot of poo all over. Right, my friend. Open. Close. Slowly open. Close. So you push it in, but that wasn't very good, but you can see how deep it goes. So you try to open it.
Yeah. I know you wanted to demonstrate the deep biopsies, but I think in this patient I wouldn't be terribly keen to do that because of the risk of most patients.
And that's it. That was round to what's left of the cecum. How long was that?